All right, psychopharmacology. This is Professor Wheeler for Nursing 255 at Contra Costa College. And in this pre-recorded PowerPoint recording, we're going to discuss all of the different categories of psych meds and then problems that they are used for, and even other meds are used for psychiatric issues. And so we're going to go into it in quite a bit of a detail. For the first exam, you'll need to know just basically the categories that you'll see on the slides. And I know it's a lot, but you don't need to know anything besides the category and the key facts that I mentioned in the slides here. I know a lot of these meds have a lot of side effects, and so you don't need to know all of those. You might need to know more of those side effects when we get into the different psychopathology, the different, when we go to have our lecture on mood disorders, and we're going to talk in more detail about antidepressants and medications for bipolar disorder, but you don't need to know that right now. What you need to know right now is just the category. What I've found in the past is that students, they, once you have it kind of in your brain, it's easier to expand it when we come to those lectures. It's a lot easier than to create it at that time. So this has been very successful. It's credited for our, they give me a lot of credit for doing these meds at the start, for the fact that our NCLEX pass rates are among the tops in the state. And so I know it seems like a lot, but it's going to pay off in the long run, and it kind of sets a foundation for this course. All right, looking at objectives. Number one, we'll explain why it's important to do a CT scan or an MRI when a person first shows symptoms of psychosis. And you do that to make sure there's not a structural problem before starting them on antipsychotic medication. And then number two, like I mentioned in the previous slide, we're going to go through the PowerPoints with all the different categories that you need to learn, and you're going to learn the medications, the name, the brand name, the generic name, and then some key facts about those medications. And then number three, there's some considerations of some medications you cannot take when you're pregnant. Psychopharmacology is the term. It means the study and use of medications that affect behavior, thought or behavior. And one of the things to know about this, if a medication, there's a certain level of consent that you need that's a little more, where you have to have them sign an informed consent when it comes to what we call psychotropic medication. In other words, medication for psychiatric use. And you even have to get that kind of consent when you're using a medication that's not a psychotropic medication, but you're using it off-label for a psychiatric reason. And that's just something to know. And then it's very common in this culture that someone will be taking medications for a mental health condition. I know there's people in the class right now that are probably, almost certainly, there's several people that are on antidepressants or anti-anxiety medication or meds for ADHD or, everything. This, one of the things about psychopharmacology these days is that it's a real dominant thing in the culture right now that I always feel like someday a future civilization is going to look back on us and say, wow, those people thought they could fix everything with a pill. So yeah, and psychopharmacology, it's made a great improvement in mental health treatment. I don't want to minimize that, but it's not everything. So we still have to teach our patients coping skills, how to manage their emotions. So they shouldn't rely totally on the medication. For the first exam, you'll need to know what psychiatric issue the medications are used for, and then you'll need to know both the generic and the brand names. Some of the questions will have both of those names, and some of them will have only one. So you do need to know both of them. And then the key facts that I list in the PowerPoint, those are what you're responsible for. I might mention a few other things on these slides, and I could hold you responsible for those since I talked about it, but the ones that are actually on the slides, those should take priority for your studies. All right, so I know you might feel a little overwhelmed looking at the list of meds you have to learn. This that you see here right now in this PowerPoint, this is actually a Facebook meme that a student made a few years ago, and I thought was quite funny. I'm sorry if it feels that way. It is a lot of work. It's a lot of memorization. I have an available article for you on mnemonic devices, how to memorize things using those kind of techniques. And one of the good things about it is if you put the effort into it, you should be able to memorize it. They're not tricky. They're just, there's hard and there's a lot of them. Students that don't do well on the first exam and don't do well on the medication parts, it's usually because they didn't really believe that they needed to know all these medications. So believe me, you do need to know them. I asked a lot of questions on them for the first exam. And so, I know it feels a little bit overwhelming, but you just do the work and you will have it down. Okay, and this is just more of me taking care of you. Take a deep breath, a lot of meds. This technique I list here, probably you've heard of it before, your brain dump, when we, all of our exams are in person, and when you go to sit down at your computer in the computer training center or computer technology center, you'll have a blank piece of paper. It's not one you can bring with you, but before you start the exam, you can write on that piece of paper. And so what you want to do is practice writing whatever mnemonic device or whatever you want to do. You can practice that over and over again at home so that when you come into the exam, you can write that down before you start the exam. And so you'll have that on your piece of paper. That's what we call a brain dump. That's one of the techniques students have successfully used over the years to get through this. And also, in case you probably understand this, but you need to know the meds for all the future exams as well. These meds, these are real commonly used for review questions, and that's because I don't want you to just memorize it and then forget it all after the first exam. Once you get all of those medications down, you'll have a significantly easier time in the rest of the course. All right, so I don't go in depth with neurotransmitters and how they work in the brain and all of that. One thing that I find is that nurses practicing in the field, they don't remember all of the little, how the nerves work, how the brain works. They don't remember that. And one of my things for students is that if my coworkers can not remember those kind of things and be great psych nurses, then I don't think you need to know that. And from my understanding, they don't ask those kind of questions on the NCLEX because the NCLEX is about making the correct decision in a situation primarily. And so So there's a lot of content in this lecture that you need to know, and then you'll learn how to use that content to make correct decisions. So, I'll go into this. These 5 neurotransmitters, you do need to know these ones, and let's go into them. So the first 2, serotonin and dopamine, these are the neurotransmitters that make you feel good. And norepinephrine, to a lesser extent, norepinephrine, it helps you have more energy. And so you'll see our antidepressants, they raise your serotonin, and some of them even raise your dopamine a little bit. And then we have other ones that also raise your norepinephrine. And so norepinephrine, it lifts your mood, but it also lifts your energy level. So it's especially good for somebody that's depressed and they're what we call psychomotor retardation. They have that symptom where they're moving really slowly and they're thinking really slowly, and it's a real physical depression. The bottom 2 neurotransmitters here, acetylcholine and glutamate, those are the primary neurotransmitters with our medications for memory. So our medications for dementia, there's 4 of our main ones, and 3 of them primarily act on acetylcholine, and the 4th one acts primarily on glutamate. All right, so these are our main categories here. There's a total of 9, and so there's some on the next slide as well. I don't think we need to go into that in any more detail. I did rename, sorry if it's confusing, but I renamed the erectile dysfunction one just medications for sexual health, because I did add the one for that has the off-label med that helps women with problems with low sex drive. Okay. All right, so our first category, tricyclic antidepressants. These were our main antidepressants that were used before the advent of selective serotonin reuptake inhibitors, SSRIs, or the more common name. And these currently are not used as much as they are for other things. So the problem with this category of medications, I have it on the next one here, is overdose is lethal. So you're prescribing a depressed person that, and one of the symptoms of depression can be chronic thoughts of wanting to kill yourself. You're giving them a means to be able to kill themselves. So if you have a patient that's been hospitalized for suicidality and this is their main medication, and we're going to keep them on that, when they're discharged, we don't give them, like a month's worth or 3 months worth or something like that. We only give them a week because we don't want them to have enough to be able to kill themselves if they get depressed. So these days, it's not usually the first medication tried for depression. Most of the time, people that are on this for depression, they tend to be older, and they started it in the 80s or the 70s even, and it worked for them, and they didn't want to change when the newer, more effective medications came out, because if it works for you, you have a certain kind of trust, and you want to stay on it. But it's rare this wouldn't be the first one your doctor tries when you're feeling depressed. It's more commonly used these days to help children with bedwetting and to help prophylactically for people that get migraine headaches. They'll have you take it every day, and it prevents the migraine headaches. Okay, this is one of the more famous categories of medications, and especially the first one there. Prozac, when it first came out in the late 80s, early 90s, it was thought of as a wonder drug, and even to the point where people would say, I don't know what is the real me. Is it that the person I am when I'm on Prozac? Is that who I really am? And the depression has been weighing me down all these years, keeping me from being who I really am? Or is the Prozac some kind of chemically altered form of myself and not really who I am? And so that was a big thing in the culture. It was a surprise how well this medication worked for depression. And probably one of the reasons why insurance companies kind of moved toward wanting to pay for you to get outpatient psychotherapy and instead wanting you to take a pill. That's how effective these medications work. I don't know. Mixed feelings about that, but that's the reality. And the next ones followed, Zoloft and Paxil, and then there's several different ones. They all are structurally very similar, so they have very similar therapeutic effects, very similar side effects. The very profitable medications for the companies. And I think I have you learn 6 of them here. And, this is not an exhaustive list. I've just tried to not have it be too overwhelming. But this category of medication is very, very common. One of the things about SSRIs, the key facts, they can increase the risk of suicide at 3 weeks. And the risk of suicide in teens, for some reason, we're not quite sure about why that is. But it can, that has been a factor. I do have some thoughts on that. One of the prominent theories is that with teenagers, when they have bipolar disorder, their elevated moods don't look like they do with adults. They look more like irritability. And to a doctor that's not that familiar, and most of our psychiatric, especially antidepressants, are given out by general practitioners and not psychiatrists, that causes the doctor to give a medication to a teen that's actually having an elevated mood with the irritability, and the doctor, misdiagnoses them and thinks they're just depressed. And so we never give an antidepressant to a person that's got an elevated mood. It sends the mood really high because the antidepressant kind of pulls the mood up, which is what it's supposed to do. And so when your mood gets too high, that's very dangerous, and that's when impulsive suicide attempts can happen. So other things that SSRIs are famous for are the sexual side effects. The sexual side effects, the inability to orgasm and decreased sex drive, and not quite so much with the excitement. As far as it doesn't cause erection problems so much, it's more like just it makes it harder to have an orgasm and decreases sex drive. This side effect is so reliable that we actually give it to teenage boys or other, it's usually young men that have a problem where their sex drive is way too high, and we can give them this to, for the side effect of reducing their sex drive. And so that's a side effect that stops people from taking it sometimes. It's something where we need to really take it seriously because, people aren't going to stay on the meds if it has a bad effect on their sex life. And, sexuality is an important part of a human being's life. And, sometimes we can see the patient only for the problem that they present with and not see that, once they're feeling better, they're going to want to have when they're out of their severe depressive episode, they are going to want to have satisfactory sex life, just like everyone else. And so if they have these kind of symptoms, we want to take it seriously. And those symptoms, you don't have to live with them. Like I said, all these meds are a little bit chemically different, and there's a lot of them to choose from. And so the doctor can change, even if they change them to a different one within the same category, a different SSRI, sometimes they still will, not have that side effect, because it's really just kind of finding the one that works for the patient, that works well enough for their depression, but doesn't give them the side effects. It's not expected that the person will live with low sex drive and inability to reach orgasm. That's not something we want for our patients. Our next category of medication, serotonin norepinephrine reuptake inhibitors, SNRIs, similar to SSRIs. Their main effect is on serotonin. With the SSRIs, they inhibit the reuptake of serotonin, where your nerve cells emit it and then kind of pull it back. And what these medications do is they stop it from pulling so much of it back, so more of it can be in the space between the cells and dock in the cell sites. And so with selective serotonin reuptake inhibitors, that only happens with serotonin primarily. And then with this group of medications, serotonin norepinephrine reuptake inhibitors, it happens with serotonin and norepinephrine. What this does is increases the patient's serotonin and norepinephrine. And so one of the good things about norepinephrine, it counteracts some of those side effects with serotonin-based medication, because it increases your energy, and when you increase the person's energy, it also increases the sex drive a little bit. And so it counteracts the side effects of the increased serotonin by, increasing energy and kind of nullifying some of those sexual side effects. So this is usually what we try if the patient is having sexual side effects from the SSRI. It's pretty much almost as effective as SSRIs, and maybe even more effective in some people. So there's the three main ones here. I know there's other ones as well. Like I said before, this is not an exhaustive list of the medications. They're coming out all the time. So this is a class of medication. One of the things about norepinephrine, it can, along with that increase in energy, it can also increase anxiety. And so this is a medication that you wouldn't give a patient with severe anxiety. Theoretically, it could increase the anxiety that they have. However, in practice, what you'll see is doctors, when they have a patient that's tried many different medications and they're not working, they will try one of these. And, you find out, when you find a medication that works for the patient, that's you try them all, regardless of if theoretically it should work or not, or if it could have a downside. So anyway, that's how that proceeds. All right, our next class of antidepressants, MAOIs, monoamine oxidase inhibitors. And what these do is they also increase serotonin by inhibiting the enzyme that is kind of out between the cells that also is there to regulate the amount of serotonin. And so it makes it where serotonin has a better chance to dock. It's not nearly as effective as in increasing serotonin. This was actually our first antidepressant that we had. I think it came out in the late 60s. And it has a limitation that we're going to talk about and the key facts here that are important. And that's one of the reasons why you don't see it very much. And yes, so the key facts with MAOIs, the big one is that it interferes with the body's ability to metabolize the amino acid tyramine. And this can lead to a hypertensive crisis. The person's blood pressure gets very high, and they're in danger for having a stroke, and all the other kind of bad things that happen when your blood pressure is skyrocketing. So foods that are high in tyramine, some cheeses, things that are really highly processed, broad beans, fava beans, pickled foods, sauerkraut, beer and red wine, the patient needs to be able to avoid those foods. And, it's hard. You give patients a list of things that they can't have, and it's also hard to have that list be comprehensive because you never really quite know what's in food products. And so we don't use this one very often. The side effect risk and the fact that it's not really that effective, it makes it where it's not quite worth the risk. All right, so other antidepressant medications, you might see these crammed into other categories, but this is the best one in my opinion. The one I may have referenced earlier, bupropion, it goes by the brand name of Wellbutrin when it's used for depression. It's also marketed as under the name brand of Zyban when it's used to help people stop smoking. It's the exact same medication, it's just marketed differently. But that is one of the things about Wellbutrin, it only works on norepinephrine, and so it doesn't have any negative sexual side effects, and it is one that we use with females to help raise their sex drive. We're going to talk more about that on the next slide, more key facts for Wellbutrin or bupropion. Then medications primarily used for sleep, we have trazodone and Remeron, and those we're going to talk a little bit more about as well. All right, so key facts about bupropion. Wellbutrin does not act on serotonin, has no negative sexual side effects, and does have the off-label use to increase sexual desire in females. So that probably brings up the question, especially with my male students, is can it increase your sexual desire in males as well? And the answer is yes, for the same reason. It increases your norepinephrine, which increases your energy. It's not really used that way though, because there are other medications that work to increase testosterone that work better for males that have problems with sexual desire, with having enough sexual desire. And we sometimes use those testosterone, that kind of thing, to increase sexual desire in females also, but we have to be careful using testosterone with females because they can get a sexual or they can get masculinized, and those side effects don't go away when you discontinue the testosterone. And so probably the most common one that females will see when they take testosterone is a little bit of hair in their sternum start to grow, and then that's there forever. And so that's usually not what they were looking for. Okay, so it does reliably reduce the desire for cigarettes, and so that helps. It makes where you smoke the nicotine, it doesn't feel as good, and so that helps people stop smoking. Patients will test positive for ecstasy on most of the drug screens that test for ecstasy, and this is an important factor because I've had, some of you know that I work on an adolescent psychiatric unit, and I've gotten referrals where I hear that the nurse in the ER has been confronting the poor 15-year-old girl about coming clean to her, about her ecstasy use. And, when they call me for a report, I tell them, hey, don't you know that, I'll find out that the child is on Wellbutrin, or bupropion, and I'll say, hey, that's why the kid is not in denial about their substance abuse. They didn't nobody snuck it in their drink at a party or anything. That they're on a medication that makes them test positive for ecstasy. And so that's real common for bupropion to cause a person to test positive for ecstasy. There are other medications that make patients test positive for ecstasy as well. So if you get a patient that tests positive for ecstasy and they're steadfastly denying it, always look into the meds that they're on and look up the side effects for those meds. All right, so another thing with bupropion, for patients that you're trying to get them to eat, somebody with an eating disorder or an older person that just is not eating enough, for whatever reason they're not eating enough, it also can reduce appetite. Okay, key facts for trazodone and Remeron. Just some things to know. Trazodone, one side effect is it can cause priapism, and what that is it's an erection that's painful. It's a very hard erection that's uncomfortable, and it's not sexy, and it hurts. It's something that can be so serious that you have to call 911, and they have to physically, put a needle in those tissues of your penis and pull out some of the blood to keep from having an injury. I haven't heard of a priapism that's that bad that required that kind of treatment from trazodone, but it's possible. And then with Remeron, besides being used for insomnia, it also can help increase appetite. So you'll see it frequently with older people that are not eating enough. All right, medications for bipolar disorder. I have them split up a little bit here. There's some medications. Well, let me go into bipolar disorder just for a second. One of the things about bipolar disorder is people have very high highs and very low lows. And so the difference between these two categories here, mood stabilizers and anti-manic drugs or medications, is that the mood stabilizers, they help with depression and with mania, and so they don't always need to have an antidepressant along with them. Whereas the anti-manic drugs, just like the name implies, they help keep the person out of the manic episodes and that side of the spectrum, but they don't keep the people out of depressive episodes. So if you have somebody with bipolar disorder that has both manic episodes and depressive episodes, they need to be on a medication for depression as well if they're on an anti-manic medication only, because the anti-manic drug won't keep them out of the depressive episode. All right, so some key facts. Lithium, which is one of our most famous psychiatric medications, it cannot be given on an empty stomach. And this is something that makes me very upset when I hear, especially if it's the first dose for the patient. One of our big challenges in psychiatry is to get patients to take their meds. And if you give a patient lithium, and especially if they've never had it, and you give it to them on an empty stomach, it's going to make them very nauseous, and then the patient's not going to want to take it anymore. They'll think that they're allergic, when it's a normal to have nausea when you start on lithium. And you just have to make sure they have food in their stomach before you give it to them. Lithium has what we call a neurotherapeutic range, and what that means is that the amount that it takes to make you toxic to have too much of it is uncomfortably close to the amount it takes to be effective. And so it has to be regulated very closely. A lot of, especially when you first start on it, everybody metabolizes medications differently. So there's not really a real easy way you can guess how a patient's going to respond. So you have to, test their blood usually every 3 days, I think is our standard. And, make sure it's not going up too high. And also you have to be giving them enough so that it gets into the therapeutic range. Some other things that stand out, Lamictal, the generic name lamotrigine, can cause what's called Stevens-Johnson syndrome, and that's a rash that's in your mucous membranes that is, it can be deadly. So it's very serious. And so they have to, part of your medication teaching with them is they have to have, if they get any kind of rash, they have to have it assessed by a doctor. And then the medications from the anti-manic category, along with lamotrigine, cannot be taken while pregnant. They cause birth defects in the neural tube, which from my understanding, develops into the brain and the spine. I mean, not the spine, the whole nervous system. All right, so some other key facts. Medications in the anti-manic category, you might recognize them because they're also used for seizure disorders. And sometimes we give them prophylactically if a patient is in a serious detox from alcohol or benzodiazepines. We will add one of those medications for the time that they're detoxing. Anytime a patient has had a history of seizures with detox from alcohol or from benzodiazepines, you always give them something that's specifically to prevent seizures. And with benzodiazepines, just an added little fact, our most dangerous one, Xanax, we try to always cover it with something for seizure prevention because it's so easy to have seizures with detox from Xanax. All right, another big one from lithium is that lithium is one of only 3 treatment choices that research consistently shows, throughout multiple research studies, it shows to consistently decrease suicidality. So it's very commonly used for highly suicidal patients.